Good morning, good afternoon, and good evening to you all. Thank you so much for joining us. We welcome those who are joining us once again back, and also to those who are joining us for the first time. Thank you so much for being here. We hope that you can share with us where you're joining us from today in the chat function, letting us know what you do, where you're from, your name potentially. And we also encourage you to share any questions you have throughout this presentation with us via the Q&A function and not the chat function. If you have any challenges finding this Q&A function, please use the More feature at the bottom of your screen. In addition, there are captions available throughout this presentation. If you have any challenges hearing the audio or if you struggle with potentially the language, please use that function to help you follow along. If we could pop to the next page, please. My name is Rihanna Harris, and I am the Senior Program Manager here at ICHOM. I will be your moderator for this webinar today. Next page, please. As always, we encourage you to stay connected with ICHOM, and we love collaborating with all of you. There's many ways that you can do this with us. As always, we encourage you to join our webinar series in the ICHOM membership. We encourage you to drive change with us with the ICHOM accreditation, partnership programs, developing ICHOM sets, and the learning collaboratives, which are my personal favorite. And as always, we encourage you to join us for our annual conference, which this year will be held from the 7th to the 9th of December in Montreal, Canada. Just to let you know, early bird sales will end on the 6th of August. We will be sharing the shortlist announcements for the abstract submissions on the 14th of September. We currently have the patient scholarship donations available, and we also will be showcasing sponsors and exhibitors at our conference as well, who will be bringing incredibly interesting innovations. Next page, please. And here is a quick highlight of a little sneak peek of what you can expect at our conference this year. There'll be over 5 hospital site visits to pick from to be able to have a little bit of an immersement into value-based healthcare within Canada. We'll be having some value-based healthcare pitch showdowns, which have gone down a treat in the past years, along with many other different features, including AI focuses and following the money. Next page, please. And today's webinar will be focusing on the ICHOM coronary artery disease set for patient-centered outcome measures. If you'd like to learn any more about this set, please use the QR code on screen. This will take you to the full set page on our webpage. Next page, please. So without further ado, I would like to introduce to you a wonderful woman who I've had the pleasure of working with over the past few years, Paula Dibert. She's the Director of Innovation for the Grupo IAG Saúde, alongside her incredible colleague, Emmanuel Lucas de Silva Rufino, who is a nurse and cardiology specialist at the Evangélico Hospital of Vila. Please, Paula, welcome. We look forward to hearing your presentation.
Thank you. Thank you. Good morning, afternoon, evening. Thank you to ICHOM for hosting this session. I'm here today with Emmanuel Rufino, cardiology nurse at the Evangelical Hospital of Vila Velha. And I will be sharing how our team took the ICHOM coronary artery disease set from concept to routine practice inside what is a Brazilian public philanthropic hospital. So this is a real world story, what we measured, what the data told us, and above all, what we changed because of it. Next slide, please. So everything you see today is shared under a Creative Commons license. You're welcome to reuse it, adapt it with attribution and for non-commercial purposes. So let me set the scene here. Where does this take place? So the Evangelical Hospital of Vila Velha is a philanthropic institution founded in 1972. It is a regional reference here in Brazil in the state of Espírito Santo for urgent and emergency cardiovascular, urological, and ophthalmological care. and it is certified for high complexity procedures across the specialties that we show here, from cardiovascular surgery to neurosurgery to oncology. So here we're talking about a public, high acuity, emergency facing hospital. So this is an important context to hold on to. It shapes what our numbers are about to show. Next slide, please. So we began this project in April 2024 with a first meeting to understand what we call the ICHOM proposal. What is the use of standardized measurement using an ICHOM standard set? And it's important that from the beginning, the hospital had management support to start this project. So from May of that year to August, we held weekly meetings to align on the standard set and build engagement in the institution so we could start collecting the acute coronary syndrome set, focusing on patients who underwent bypass surgery. In 2025, we scaled collection and began capturing 12-month proms and continued through 2026. So notice that there was some speed from first contact to routine collection. This happened pretty fast. So let me show you how we implemented it day to day. Next slide, please. So implementation rested on what we think are three pillars. First, an initial methodology where a follow-up spreadsheet was used, informed consent was collected, and the patients were contacted by telephone. Second pillar is human resources. So Emmanuel here, who is our cardiology nurse and the multi-professional nursing residence team embedded and brought to them data collection. And they became a reference for patients and they became a reference for care navigation for these patients. And this is really important. And third, continuous improvement. So constantly refining the platform that we use to record this data. And this is what we think was the base for the whole project. One of the most important things is that neither the nurse nor the residents just collected data. They became the patient's point of contact and their navigators. And this is what made follow-up sustainable. Next slide, please. So data collection in admission had the application of the consent form and interview, post-discharge nursing and cardiac surgery consultation at the outpatient clinic with a new follow-up completed. Follow-up had interviews by phone or a visit to medical records since patients continue follow-up with cardiology. And of course, there are challenges. So telephone follow-up is subject to loss of follow-up. And we do have some scheduled delays due to the high number and frequency of monitoring, but no patient is lost from admission to discharge. They're all followed up and guided, even though one of the challenges that we have is to appropriately time the follow-up with the patients. Next slide, please. I think that one of the most important things is getting the patient voice out of the set. So we brought here three screenshots of patients that answered the ICHOM standard set. And you can see that they're really happy when they're asked about their current health situation. So thank you for taking so much care of me. I'm still recovering, but a lot of gratitude. My recovery was excellent. I even worked on building a wooden staircase, and that's really interesting because these are things that you hear only when you're in contact with the patient. I am well, taking my daily walks, eating normally, taking my medication. Thank you for following my recovery process. So you can see here that these aren't just decorative quotes. Uh, this is the reason why we measure outcomes. Outcomes that matter to the patients are the whole point of value-based healthcare. And this we can only hear about this when we make the effort to actually ask them about what is important to them. So this is really, really special. Next slide, please. A short but important note on how to read our numbers. We analyzed what we call 11 checklists. Checklists is a strategy that we use to divide the standard set into multiple data points of collection or different ways to collect these different data points of collection. So we analyze what we call 11 checklists, and I'll read them to you on our next slide. But today, the total cohort that we have is 338 patients. Of those patients, we have 307 patients who completed what we call clinical checklists, with 31 still awaiting follow-up. And you also see that we have 511 records in the PROMS follow-up checklists. And this number is larger, not because there are more patients, but because PROMS are applied repeatedly at baseline, 30 days, 3, 6, and 12 months, and then annually up to year 5. So the denominators shift depending on the analysis, and this means that we're seeing multiple records per patient. So when you see the numbers, keep that in mind. Next slide, please. So these are what the 11 checklists of the CAD set. So from the demographic factors and baseline health status through the treatment variables, acute and surgical complications, functional health status, disease progression, and survival, each of these checklists are collected on its own schedule from baseline out to 5 years. So I won't read them all. I'll simply note that together they cover the full ICHOM domain structure. So how complete is our collection across these checklists? So this table shows for each checklist how many unique patients and how many records we hold. So you can see that for demographic factors and baseline status, we cover our entire cohort. Surgical and acute complications sits around 306, 307. Those are our operated patients, by the way. And look at functional health status and disease progression. We have 504 to 511. So again, this is the longitudinal PROM effect. So the collection is broad, it's pretty deep, and the volume of records is a sign of sustained follow-up, and we're not double counting. Next slide, please. If we ask, has this checklist ever been done for the patient? So we have high coverage. We count any record at any time. And this tells us that the data we need exists and that the process put in place is really working. But that is not the same as asking, is it done on time? So next slide, please. We ask instead, was the checklist done within the expected window? And then you see that the number drops because now we're measuring timelines. And to be really honest, this is an honest, important finding from our side that the data exists, the collection is robust, but when we start talking about the timing of follow-up, this is one of our real bottlenecks. Even though we're having 100% retention and no patient is being excluded, one of our main challenges is collecting on schedule. So that reframes the whole improvement agenda, and this is an item that we're actively working on. Next slide, please. So we're going to talk a little bit about this group of patients. So our cohort is of 338 patients, as I said before. We have a mean age of 64 years. About 3/4 of the patients are men, 1/4 are women. We're concentrated here in the sixth and seventh decades of life. And this is a typical bypass surgery demographic. And a reminder that these are older and higher risk patients. And next slide, please. You see that these patients, they carry a substantial burden of comorbidity. So at baseline, 84% of the patients have hypertension, 44% have diabetes. Beyond that, you can see heart disease, myocardial infarction, obesity, and a long tail of other conditions down to depression. So, I mean, this comorbidity load is exactly why risk adjustment matters when we compare outcomes. A point will come back when we'll talk about these outcomes. So let's turn to the surgical outcomes. So here are the major post-bypass complications split between the index admission and the first 30 days after discharge. The three tracked most closely are prolonged ventilation beyond 24 hours, deep sternal infection, and reoperation. So two of those stood out as unusually high, and rather than hide it, we made them the focus of the improvement work. This is also one of the highlights of this project. Next slide, please. So tracking this year, year over year, this is the real story. So we see here that for deep sternal infection, the red line, it falls sharply from 2024 to 2026. Prolonged ventilation stays relatively flat, and reoperation stays low. So the falling of the infection curve is not luck. It's the result of a deliberate structure response that I'm going to share with you on our next slide. So the high infection rate was discussed extensively, and through the improvement groups that were done inside the Evangélico Hospital, the Skin Committee, and the Hospital Infection Control Services, some actions were brought into life. So strengthening of hand hygiene practices, adopting more advanced dressings where financially feasible, structured training, and an institutional study to characterize those at-risk profiles for deep sternal infection. So this is value-based care in practice. It wasn't just measurement, and it wasn't just a bad number. That was convened into assembling the right people and acting on it. So the documents at the bottom are the consensus guidelines that informed the hospital on the different approaches it should take for diminishing the external infections. And next slide, please. For 30-day mortality, the large majority of patients survived, 284 patients with no events, 20 deaths during the index admission, and 3 after discharge. On the right is the context. So nearly 1 in 5 cases, so up to 20% were urgent or emergent, not elective care. And when we're talking about an emergency facing public hospital, that case mix pushes mortality upward. And this is why raw unadjusted outcomes can mislead and why risk adjustment is essential for fair comparison. Next slide, please. So this is the core of our study. The Evangélico Hospital of Vila Velha is a philanthropic hospital operating within Brazil's SUS, the Unified Healthcare System, serving a mixed population with very different social realities, different comorbidity burdens, literacy issues, and income. And the outcomes are shaped by public policy both inside and beyond the system. So this is what makes real-world ICHOM implementation in a public Brazilian hospital distinctive. Next slide, please. Next slide, please. The slides are frozen, I think. Or am I frozen?
I don't think you're frozen. I think she might be bringing them back up. One moment.
Okay.
Oh, I'm just going to try and share this
Okay.
myself a moment. If you want to start elaborating on any of the slides, please feel free.
No, go ahead. I'll wait for you. I think it's good to have the image to follow up with the numbers.
No,
No
absolutely.
worries.
Apologies. Some technical difficulty is always the way with working remote.
Do you want me to try and share the slides?
If you have them available, please feel free.
I do. Let me try. Just a second. Can you see the slides?
Yes, we can. Perfect. Thank you.
Okay, perfect. So this slide talks about it's another data point collected. So it talks about tracking major, oh no, I'm back. Sorry, just a second. Here, this is what I want. So this is we continuing to track some complications. So two further complications of the intervention are stroke, which was rare with 5 cases, and acute kidney injury was more frequent at 28 cases, both tracked as part of the set. and both feedback into improvement discussions. This is where it gets really interesting because we're seeing here the patient reported outcomes. And this is what it's different about collecting ICHOM sets. So on the left, we see that angina frequency in the last 4 weeks. Most patients report none, though a meaningful group still has weekly symptoms. And on the right, we see shortness of breath using the Rose scale, and around 69% of patients report shortness of breath on strong exertion. So, like running or climbing, falling to about 6% for basic activities such as bathing or dressing. And this is exactly what we'd expect. And having this baseline gives you a clear number of what you're working to improve against. So here we have the angina control over time. So the percentage of patients in the best category from baseline to 1 year, you see that the line rises across every measure. So we have more patients free of angina, fewer patients needing to use nitroglycerin, and more saying that angina no longer limits their enjoyment of life. So this is the improvement that the patient actually feels. So this is the beauty of measuring patient-reported outcomes. And the same we see with shortness of breath. So it improves across all activities from baseline to 1 year, whether we're talking about climbing a hill, walking at their own pace, or personal hygiene. And functionality, the percentage without limitation climbs steadily for walking around the house or gardening or lifting heavy objects. So if we take together these three slides, these are the payoff of value-based healthcare. We have measurable, patient-reported recovery over the first year. This is the result of this beautiful hospital's work with their patients in this line of care. And these are the three slides that we're really happy to share. And again, it shows the importance of bringing out patient-reported outcomes out of what the patient is experiencing in his life, and it's unmeasured and not talked about, into structured data that is going to continuously educate teams on how they're doing and what they need to improve. And here we can see that for depressive symptoms, even the screening for depressive symptoms is really important. So little interest or pleasure in doing things or feeling down or hopelessness. Most patients respond never, but the tail matters. So screening lets us identify and support those patients who need us during care in regards to emotional well-being. And again, emotional well-being over time, the share answering never rises from baseline to 1 year. And this shows that recovery is not only physical. When we're treating patients, or the data shows that the psychological dimension is improving with their clinical dimension as well. So let me bring it all together, where we are and where we're going. So we have had a really important improvement with deep sternal infection, falling from 17% in 2024 to around 7 or 8%. in 2025-26, so a more than 50% reduction after perioperative bundle was put in place. And this is at a phase of consolidating this bundle as a permanent protocol. Prolonged ventilation is still stable. It doesn't have a dedicated bundle yet, but we will extend the same structured action model with early extubation and a pulmonary assessment of smokers. On shortness of breath or dyspnea, absence of breathlessness rose from 63 to 87% over 1 year. And this is a clinical evidence to continuous work on this patient and prioritize rehabilitation. Retention today is 100%, but we do need an on-time coverage. And this is going to be improved with proactive contact and also automate follow-up reminders. And across every PROM domain, we see consistent improvement. And our goal now is to turn PROMs into an active clinical alert, not just a retrospective record. So if you want to take one slide away today, this is the one. And I like to thank you. This work is a result of a very dedicated multi-professional team at the Evangélico Hospital of Vila Velha, in partnership here with Grupo IAG Saúde. And Emmanuel and I would be glad to take your questions. Our contacts are on the screen, so feel free to reach out to us. And thank you very much for this opportunity. And just on a quick note, you might ask your questions. If you're in Brazil, you can ask your questions. Se você está no Brasil, você pode perguntar em português. If you're not in Brazil and you ask a question, I'll redirect it to Emmanuel and I might have to do some translation. So just bear with us a little bit. Thank you.
That was absolutely fantastic and incredibly enlightening. The work you've done, I think, shows a lot of people around the world some really meaningful change, and hopefully will inspire a lot of people to do a lot of things to better the care, especially in this very specific set region. We have some questions coming in if you're happy to start answering them. To start off with, we have some questions more so around the checklist and the time points you spoke about. With the first one being what your definition of on time is with these windows. How did you define how broad the windows would be? And how are you going about ensuring that the data is collected as close as possible? I know this was one of your bottlenecks, so if you could elaborate on that, that would be wonderful.
Ok. Emanuel, como que vocês definiram o que você chama de coletar no tempo da janela? Eu sei que foi criada uma janela, né, para poder fazer a coleta de dados naqueles diferentes pontos de 1 mês, 3 meses, 6 meses. O que que você considera que você respondeu no tempo?
Ai, então, primeira coisa é que esse tempo ele já vem especificado na coleta junto com os checklists.
Sim.
Só que a gente tem que adequar a nossa realidade, e a primeira coisa de adequar a nossa realidade é entender que os nossos pacientes eles têm acompanhamento cardiológico periódico.
Uhum,
Então, vem no pós-operatório, depois vai para o cardiologista com 6 meses, um ano, e aí a gente consegue construir uma janela sempre acompanhando esse paciente até pelo nosso prontuário.
Okay. So the timeline's already set by the ICHOM standard set. So what they consider on time is that this patient already has a follow-up. So the patient is being on post-op. He's going to see the cardiologist at 6 months, at 1 year. So they tie the timelines to the follow-up inside the hospital.
So building on that, how big are the windows that you allow for that 6 month checkup? Are there any leeway? Does it have to be within an exact window? Is it broad or is it quite specific?
E você coleta sempre assim, com 6 meses, com 1 ano, ou você permite uma janela?
Então, Uma das coisas que a gente colocou, até no slide, a gente colocou como um desafio, é justamente essa coleta na janela
Uhum,
que você está perguntando, como que funciona para nós, né?
uhum,
Essa janela, ela vai variar. Às vezes o paciente vai ser acompanhado até 3 meses e depois vai
uhum,
ser no próximo ano, mas
uhum,
sempre no sistema, a gente criou um sistema próprio, que é uma planilha, que avisa quando todos os checklists desse paciente vence. Quando a
uhum,
gente preenche um paciente no checklist, numa janela que não é aquela, por exemplo, de 3 meses, ele vai automaticamente no sistema realocar para 3 meses no futuro, para 6 meses
uhum,
no futuro. Então, eu
uhum,
sempre vou ter uma previsão de uma nova data, entendeu?
uhum.
Ele nunca vai ficar sem uma nova data.
Okay. So I mean, the window is the is really the biggest challenge. So there's no fixed window. They have a system put in place where they alert each of the patient's timelines, because this is something really important, right? When you're collecting ICHOM sets, is that each patient has its own timeline. So it's not everyone who's going to be collected in July. Not everyone's going to be collected in August. Patients are at different timelines all the time because they're coming to the hospital at different days all the time. So they track when each patient is set for a number of questions using the timeline from the set, and they either know that the patient is going to be at the hospital for follow-up and they use that time to collect it, or they're going to set up a different moment. If that patient's not going to be on follow-up and it needs to be data collected, they're going to either put this patient to be collected a bit further or contact him prior to visit.
Fantastic. And looking a little bit forward, do you have any intentions or plans in place on how you plan to improve that window of ensuring that the checklists are collected within those timeframes?
E acho que você falou já sobre isso, né, Manuel? Já tem algum plano de ação, alguma ideia para poder fazer com que essa coleta nos pontos certos aconteça? Superar esse desafio?
Então, isso daí já seria a automatização também, né?
Uhum.
E aí até a gente tinha conversado a questão do WhatsApp, de receber mensagem, é
Sim,
basicamente isso, automatização.
sim. We've been talking about this. So we want to automate we want to automate prompts, the prompt questions to the patients without being dependent on doing it manually, even though there's a semi-automated process working. And also, what's really important here in Brazil and that we're developing together is to have the prompt questions sent via WhatsApp. When we're talking about reaching patients over the phone, when we're talking about reaching patients at point of care, these sometimes become challenges. And WhatsApp in Brazil is the easiest technology to reach patients. So if we can automate prompt collection using WhatsApp, that will help us get more in time with the timelines.
Fantastic. Well, I look forward to seeing everything that comes from that and how that changes things for you. We do have a few more questions focused around how the data is used and who it's shared with. Firstly, some questions around whether the patients see the data, whether you have a dashboard, whether this is used in decision making, and potentially what the patient's reactions are to this information.
Acho que essa é a pergunta mais importante, né? É sobre o compartilhamento de dados, desses dados, Emanuel, dentro da instituição. Como vocês fizeram? Vocês têm, por exemplo, um dashboard que é compartilhado com todo mundo, tem uma discussão de equipe, e o mais importante de todos, assim, o paciente tem visto esses dados, a gente já conseguiu chegar até o paciente com esses dados, o que que eles sentem, né, em relação ao dado, se você puder explorar isso um pouco mais.
Eu acredito que a gente ainda está caminhando, né? Nesse período, acho que a gente foi a terceira vez que a gente realmente viu tudo aquilo que a gente está fazendo, até a questão
Uhum,
das infecções, entre outras coisas. E aí, é, o compartilhamento, ele vai ser feito de certa forma, mas principalmente eu acho que a gente tem que pensar como já agir, né?
uhum,
Diante de todo esse processo até chegar aqui, toda vez que a gente analisava, a gente já agia, né, de uma certa
uhum,
forma. E eu acho que isso que é o must, assim, né, do, do
uhum.
nosso do nosso programa.
That- the team, the data is shared among the team. And what Emmanuel strongly points out is that every time that the data was shared among the team, it was analyzed and acted upon. So this is what's important, that you just don't have data sitting around, that you analyze and act on it. So primarily it's being shared among the team, uh, and not with patients. And I think this is also a challenge. This is just me saying, I think this is a big challenge that we all have with patient outcome data, right? To involve the patient and also getting to know the beautiful results that they reported. So this is really important.
Absolutely. I'm taking this question on a slightly different angle with sharing the data. There's questions here wondering whether your payers have used or responded to any of your results and if they're involved in any of the conversations around the use of the data.
Ok. Essa pergunta é interessante. Ele perguntou se sua fonte pagadora sabe que você está coletando esse dado ou se viu esses resultados com vocês.
Inclusive está do meu lado, né?
Ah,
Então a gente tá, com certeza sabe, né?
aham,
A gerência sabe, inclusive a direção, a gerência, todo mundo participou do início do ICHOM e eu acho que é isso que impulsionou o acontecimento, né? A participação e também a disposição de literalmente, assim, vamos botar assim, carregar, né? E fazer isso de forma bem feita com o que a gente tem.
okay. So he said yes, and we actually have his high-level management here together with us on the webinar. And having high-level management, and everyone involved with reimbursement in the project is one of the things that also push this project forward, understanding the results.
Mhm. And if there was a organization in a similar boat to yours, a bit more premature, if you will, what advice would you give to them to create these relationships that you have to be able to make these improvements?
Ok. E se você tivesse uma organização aqui agora que fosse menos madura que você e que quisesse seguir esse trabalho que vocês fizeram, né? Que conselhos que você daria para que esses relacionamentos, esses incentivos fossem criados da mesma forma como vocês conseguiram criar aí no Hospital Evangélico?
Eu acho que a primeira coisa é a comunicação, né? E a delimitação do que a gente vai fazer, né? E que foi o
Uhum,
que a gente fez nas reuniões. A gente determinou o checklist, determinou o que iria fazer, quem ia fazer, como seria feito, até
uhum,
chegar a parte da coleta, que aí é
uhum,
difícil,
uhum,
porque é uma parte que a gente tem que treinar um pouco, né? A gente tem que
uhum,
ver como funciona nos primeiros meses e depois ir ajustando. Quando
uhum.
chega a parte já da análise, da primeira análise, a gente já observa e tenta agir no que precisa.
Okay. So first thing, communication. So communicate the project. You have to limit the scope. So understand what your scope is, who's going to do it, when it's going to be done, what's going to be done. Train everyone and adjust the process as you go along. But first thing to do is just share a vision.
Like any good relationship, good communication. I like to hear it.
Yeah.
We have some questions more around the data itself and the actions that were taken after seeing the data. One of the questions asks if you could potentially elaborate on how you adapted clinical practices to see these improvements. And we have another that's asking whether you potentially have any statistics from how the clinical pathways were working prior to your adaptations and I suppose redirection to improve them.
Acho que a pergunta é se vocês, antes do projeto, o que que você vê antes e depois do projeto? Como que era essa sua linha de cuidado? Como que eram os indicadores da linha de cuidado? Depois que você começou a fazer a coleta, as melhorias que foram feitas, né, a partir dos dados e como que vocês enxergam essa linha de cuidado hoje?
O hospital, ele já é um hospital acreditado, assim, né? Ele tem ONA nível 3. Então, ele tem
Uhum,
muitos processos bem estabelecidos,
uhum,
de infecção, processos, entre outras, unidades, né? Aí, o que que
uhum,
acontece? Antes disso, a cirurgia ela já tinha um acontecimento, ela já tinha um processo, ela já funcionava. O nosso set pega a doença coronariana, mas só a parte de cirurgia de revascularização. Então ela
uhum,
funcionava muito bem, só que funcionava até o retorno no ambulatório. Então,
uhum,
depois, a partir da inclusão do SET, a gente começou a ver, a acompanhar o paciente integralmente, né? E a ver quando o paciente volta. A gente fala, esse paciente voltou, mas eu acompanhei ele com 6 meses. O que aconteceu? Esse paciente foi na consulta com o cardiologista, a gente percebe isso e, e a gente consegue também ver que o paciente ele se sente acolhido, assim, ele se sente assim, poxa, eles vão cuidar de mim.
uhum. Muito interessante. So he said, just on a note, the hospital is already accredited here in Brazil with national norm of accreditation called ONA 3. This means that the hospital has very well established processes. So even before data collection, we're talking about a hospital with very well established processes. And the cohort that we're talking about is the cohort who went um, through surgery. So prior to data collection, they were seeing this patient after surgery, so on post-op, and they didn't have this integral follow-up with the patient on different months, different timelines. So after starting data collection, they extended follow-up into other timelines, and now they can track patients and track their evolution or track the problems closer closer than they did before, and patients are really feeling that they are taken care of now, that they have a longitudinal follow-up with different time points other than just having a post-op surgery consultation.
Fantastic. And has these results that you've seen so far amended more ways in your clinical pathways? I guess the processes that would typically, the patient would typically go through with this diagnosis?
Do you mean if they change something in the process? Is that
Yeah.
your question? Sorry. Vocês mudaram alguma coisa né, no processo, né, no mapa de processos mesmo, no processo de vocês anterior para depois da coleta de dados?
Mudamos. A gente, várias coisas, de infecção,
Aham.
de acompanhamento psicológico no pré-operatório,
Ah.
internado, né, no paciente internado. Então, assim, foram uma sequência de coisas que foi mudando.
He says they changed a lot of things. And just on a note, for example, infection control, pre-op psychological consultations, admission psychological consultations, among many other things that they changed in the process.
Fantastic. And I'm glad you mentioned the infection control. And we've had a couple of questions come through specifically regarding that, with folks wanting to know if you were using the Society for Thoracic Surgery's definition of a sternal wound infection.
Ok. Perguntaram aqui se vocês usam a definição de infecção de externo da Sociedade de Cirurgia
Do
Torácica.
STS, né?
Yes.
O que que acontece? A, a, a estatística apresentada de morte, ela foi geral aí, né?
Uhum,
A gente não fez essa correlação, né, do Euriscore 2 do STS. A gente tem
uhum,
validação no Brasil por Euriscore 2, que a gente usa no hospital, né?
uhum,
Mas para fazer, teria que refazer ainda.
uhum. Ok.
Teria que pegar analisar cada paciente e a gente correlacionar. Então, isso não foi feito ainda porque a apresentação aqui foi geral. Mas é
Okay.
uma coisa que está até anotado aqui.
Okay. He said that yes, they use STS definition for sternal wound infection. What they did not do is make the relationship with the SWI infections with ERO score 2, but the definition is that one.
Fantastic. Going back to some of your data, a lot of members want to know whether the data is being processed manually or whether you might have a sophisticated specialized software platform or system in place to support you with analyzing the outcomes data.
Ok. Vocês estão analisando os dados manualmente ou usando algum tipo de sistema que ajuda na análise de dados?
Manualmente, né? Aí
Ok.
a gente faz manual no Excel.
Ok. Manually.
Wow, that's very impressive. Um, I suppose that tells us a little bit of an answer to another question here, but not necessarily on your intentions. There's some questions here wanting to know whether you are, obviously, you're currently looking at progressive involvement data with patients. They're wanting to know if you would be potentially looking at doing predictive data using technology to create the predictions.
Ok. Vocês já pensaram em algum momento em usar esses dados para criar predições para os seus pacientes?
A
Mal vai
gente
poder
começa a
pensar,
pensar
né?
agora, né?
É,
Então a gente pode começar a pensar agora. Inclusive,
é.
com relação a já pegar o STS e o score dos pacientes e a gente começar a predizer, né, quando eles fazem.
Já gostei. I mean, the answer was no. I knew that one, but now we're thinking about it.
Fantastic. We always love collaborating on ideas here. Uh, we do have a few more questions. I hope we are not exhausting you currently. But there are some questions wanting to know whether this project required some additional budget to carry out the work, whether it required further staff time, to support with the follow-up questionnaires. How did you manage it? How did you gain onboarding with your leadership? And how long did that take?
Ok. Vocês precisaram ter algum adicional de recursos, Emanuel, para que esse projeto acontecesse? Algum dinheiro que entrou, aumento de equipe, aumento no número de horas? Porque isso fala muito em relação ao apoio, né, que é dado pelo projeto, pelas gerências, né, e as dificuldades que a gente encontra para começar um projeto dessa maneira.
Não, não precisou ainda, né? Mas a
Uhum,
gente está caminhando, eu acredito que no futuro possa precisar, né?
uhum,
Consequente para um projeto dessa magnitude, até mesmo para suportar as tecnologias que a gente com certeza visa instruir, por exemplo, a questão das predições, vai
uhum,
conseguir predizer no sistema quando o paciente fala que tem angina, essas coisas. Então,
uhum.
eu acredito que no futuro, sim.
Okay, so I think this is actually a really good point. It was shown on the slides that they're working with their own team. So there was no budget involved, just reorganizing their own work. You see that Emmanuel here is the head of the project, and he also works with his cardiology residents. So they embedded the project with their activities. But because this is such a robust project and it's going to be an ongoing project for many, many years, of course, he envisions that at some point we will need some sort of a budget intake, whether it's to support different technologies or more personnel to actually track and follow up with patients. But so far, no budget needed to be increased for the project.
Fantastic. Another question here, wondering when you look at the statistics at the beginning, how do you begin going about figuring out what your adjustments will be to improve those outcomes?
Quando você olhou os dados lá no início, qual que foi a sua linha assim, de pensamento sobre o que você deveria fazer, né, com aqueles dados? Ou, por exemplo, aquele trabalho, acho que aquele trabalho que vocês fizeram sobre a infecção, né? Como é que vocês chegaram à conclusão de que aquelas que eram as ações que tinham que ter sido tomadas naquele momento?
Observação, eu acho que
Uhum,
observar o que está acontecendo e a gente usar da ciência, de tecnologia. Então, o que
uhum,
está falando hoje sobre infecção?
uhum,
Quem é expert, né, fala sobre
uhum.
isso. Então, a partir disso, a gente foi realocando e atacando nos pontos principais.
Okay. So observation. Looking at the data and seeing what was happening and what needed to be improved, and using science and technology and expert information to define what were the most appropriate actions for what they saw that needed to be improved.
Very interesting. And I will give you one final question before we run out of time. One here is that are these lenses being applied for other conditions or in other departments in the hospital? Have these been shared across your organization?
Ok. Vocês estão coletando algum outro set na instituição?
Não, ainda não.
Okay.
É
So
o
current.
piloto.
Não vamos morrer no piloto. So currently they're collecting just this set. But of course, there's always room for more. And there's a question here in Portuguese, so I'm just gonna give that one to him. Vocês conseguiram correlacionar a melhoria dos resultados com a redução da utilização de recursos?
É uma pergunta, assim, bem lógica, interessante,
Uhum,
porque todo mundo, a gente se pergunta sobre isso.
uhum,
No início, a gente tinha taxa de 17% de infecção.
uhum,
E aí a gente usava de maneira inadequada os nossos recursos para cuidar da ferida operatória, de alguma outra forma.
uhum,
E isso foi para 7%, né, até
uhum,
hoje. Então a gente incorporou algumas tecnologias mesmo, e a gente percebeu, assim, de certa forma, uma redução no nosso custo, né,
uhum,
a partir daí. A gente teve incorporação de dentista na nossa equipe também,
uhum,
psicólogo, então assim, foram outras coisas que a gente foi identificando, e com certeza
uhum.
já era menos.
Okay. So he said this is a very logical question, and I think this is where we see how this is really, really useful. So, taking infections, they came from a 17% infection rate to a 7% infection rate. So, all those resources that were used to treat infections really brought down the cost when you come from 17 to 7%. And even though they have added services, they have added technology, they've added services like dentist appointments or mental health appointments, these are still cheaper than treating all of those infections.
That's quite significant. My apologies, I got the timing wrong. We are still go for another 30 minutes and we have plenty more questions to use.
Okay.
Another one we have here is what is your advice to those who are thinking or starting value-based healthcare?
Qual que é a sua recomendação para as pessoas que estão pensando em começar na saúde baseada em valor?
É, é pesquisar o que é conhecer, porque a gente tem que conhecer primeiro o que é,
Uhum,
e desse conhecimento entender a importância daquilo que é a saúde baseada em valor.
uhum,
Que, e eu acho que, de certa forma, o primeiro, assim, é o paciente, entendeu?
uhum,
É entender, é fazer o paciente entender que ele foi valorado, entre aspas, né? Acho que
uhum.
seria essa palavra.
So first thing is research and study. Understand the importance of value-based healthcare. From this knowledge, understand the importance of value-based healthcare, and understand that the patient is number one. And what value-based healthcare is going to mean is that this patient is going to feel valued, and everything that you're going to do derives from this.
Fantastic. Another member of our audience today has asked if you are using prems as well as proms.
Você também está pesquisando experiência, Emanuel, fazendo PREMS?
Como assim?
É aqueles indicadores de experiência do paciente, por exemplo, NPS.
Pega. Tem NPS, a gente já faz. Aham, sim.
They do NPS and track patient experience as well.
Very interesting. Going along with that, we do have another question that is asking, when you analyze the data and you have potentially an algorithm in place, whether you have potentially automated or manual alerts that get sent to a team when there's anything concerning that you're seeing in your results.
Ok. Vocês já automatizaram, por exemplo, que caso o paciente responda a algo que seja um alerta, né, e que a equipe precisa ver, que vocês recebam esses alertas automatizados, como, por exemplo, no painel de navegação?
Isso aí diz respeito ao painel de navegação que a gente conversou, né, para melhorar,
Aham,
a gente vai receber por ali, né?
é.
Então, sim,
Sim. We do have within the platform that they use, we have a navigation panel. We still haven't programmed it for it, but you can program each question and each answer to generate automated alerts to different clinical professions involved in data collection. And this is our next step, actually, to have this navigation panel up and running. But it's possible. I mean, the technology part is possible already.
Oh, my apologies, I was on mute. Um, Fantastic. That sounds like an incredible journey that you'll be going on, and we look forward to seeing any results you can share with us. I don't think we have any more new questions that are coming through at this point. My final question to you probably will be whether you'd be happy sharing with us what the most important lesson that you've learnt to date on this journey.
Ok. Manuel, lição mais importante que você aprendeu nessa jornada?
lição mais importante, eu acho que é ser perseverante, porque lidar com os pacientes, as pessoas que estão sofrendo de um modo geral, né, é difícil, mas perseverar naquilo que a gente acredita, né? Então, tipo assim, vai funcionar.
Muito bem.
Mhm.
So the most important lesson is to be persistent in what you believe and what you think it's going to work. It's not easy. It's hard to deal with patient suffering, and it's hard to get a project like this up and running and through a pilot phase, right? So you have to persevere in what you believe, and this is Emmanuel's lesson from the work.
How incredibly moving. Thank you so much for sharing that with us. We have had one more come through if you're happy for me to share that with you.
Sure.
A question here is previous to the implementation of the ICHOM program, what was happening to patients after discharge? Were they returning to the care of their cardiologist or GP? And are those patients now being followed at your hospital?
Okay, this one I can answer because he talked about this a little bit earlier. So at first, the process was that they had a follow-up consultation after surgery. And after implementing the set, they started following up with patients on different timelines, specifically the timelines that are defined by the set. So 3 months, 6 months, 1 year. So instead of just having a post-op consultation, now they have a timely follow-up care after surgery.
Fantastic. Thank you so much for sharing all of your answers. I have no doubt this has helped an enormous amount of people who have joined us today. Hopefully you've inspired them as well. So I really, really appreciate both yourself and Emmanuel for joining us. Thank you so much. We are delighted to work with you. We're delighted to speak with you and we're delighted to learn from you. So we share our gratitude. Um,
Thank you.
no problem. To everybody who has joined us today, thank you so much. We will be sharing the recording of this webinar on our webpage as well as in our newsletter. And we like to remind you of next month's webinar, which will be Better Outcomes, Smarter Spending, how the EMC and Bupa Arabia are transforming musculoskeletal care. This will be on the 19th of August, 2026, and it will be held at 2 p.m. British Standard Time. Please feel free to scan here to register. We appreciate all of you joining us, and we hope to see you all soon. Thank you so much.
Thank you.
Thank you. Take care.